So small fiber neuropathy in POTS and orthostatic disorders comes up often. And one of the questions is asked is why does it matter? Why is it important? And the answer is it is important because it might be relevant to what's going on. So there's important concepts to sort of go through, and it's been discussed much this past year, 2022, in much of our patient meetings, one-on-one appointments, and also in our research and publications. One of the things is that blood is always being pulled down due to gravity, and your baroreceptor sends signals down to squeeze the microcirculation, the veins through nerve to venual squeeze to push the arterial vein, squeeze blood vessels back up. That mechanism can be impaired either to some type of mechanism, various mechanisms from autoimmune, nerve injury to that connection, or sometimes conditions like Ehlers-Danlos, where there's misalignment of the collagen of the nerves that lead to impaired blood vessel squeeze by the nerves not really squeezing the blood vessels correctly. So small fiber neuropathy is important for people with POTS and orthostatic conditions because it can lead to impaired blood vessel squeeze, so the blood pools, sags, and drops. And this can lead to people feeling orthostatic symptoms of feeling brain fog, lightheaded, fatigue, standing up, feeling woozy, near fainting, and fainting. Only a few faint because people often have enough mechanisms of sort of self-awareness to protect themselves. So people usually feel very fatigued, run down, exhausted, and just reduce exercise tolerance. Things that people can often find on physical exam when you look at somebody are low blood pressure, because if the blood vessels are not squeezing this microcirculation, this is not big blood vessels like the aorta or the heart is actually a big blood vessel on some level. You'll see things like low blood pressure. The top number, the systolic, will be 90 or 80 or 70, or in a case where you're used to have high blood pressure, suddenly your blood pressure is dropping, or suddenly you don't need your blood pressure medicines as much anymore. Other things you will see is skin color changes, where you're seeing blue, red legs, or livedo reticularis, that's striping, that blue and white striping of the legs. Things we'll see also in the neurologic exam, we examine people, or things we'll see with sensory exam changes and reflex decrement or reduction of the exam that we can pick up on exam. But it's important to pick up someone who has small fiber neuropathy because it can lead to answers why you have this condition, treatments, and mean to really designated aspects of why this is occurring, concentrate treatments, medications, and very deliberate care treatments. So it's not just a diagnosis and so what. It can mean much to answers. And some of our research that we've done, about 25% of our patients have at least something on exam, and about 25-30% of patients have abnormal testing. So the testing's tricky because often the testing we'll do is skin nerve biopsy, which is really just picking up the very far distal last part of the body of the foot and distal part of the leg, and that can still miss things because the injury might be more to the core of the nerves. These nerves go all the way from the skin up to the spine, and it can still miss it. The injury can be more proximal to the core, not so distal to the skin, and people can still have maybe exam findings, low blood pressure, skin changes, and the skin nerve biopsy be normal. The problem is the injury is not where that sampling was. The example I always give as an analogy is you throw a fishing rod in the water and you don't catch the fish in the water. It doesn't mean the fish didn't exist. You just missed it. So skin biopsy is helpful, but not complete diagnosis. The other test we use is the QSAR, which is that sweat test where you put these cups to measure sweat output. The reduction of sweat ties into how the nerves are functioning for small fiber for output. There's no report of how much sweat you do or hyper sweat. It's an absence of sweat or reduction of sweat. So your arm, leg, distal leg, meaning more to the calf area and foot, and how the nerves are not functioning. It gives a little more of a bigger area to cover, and it gives you an idea about not about the functioning of the nerves. So the nerves are functioning besides the skin nerve biopsy. It's more about what we call length dependent, that typical like you see of the length of the nerves, the more far part of the nerves, a typical pattern of neuropathy being more length dependent. So the QSR is a little more helpful, gives you a little more area of the body to cover. But again, the QSR can miss it because it's only picking up the more distal end part of the nerves, and people can have injury that's more core. So people can have issues still with normal testing. And that's why we always recommend to be a composite of history of what's going on with people, symptoms, autonomic symptoms, what other neuropathic symptoms of tingling, burning, do they have low blood pressure, do they have skin color changes, and the testing is supportive. We look at everything together and review it in the visit and in follow-up visits, more like a scorecard of we look at someone with small fiber neuropathy is not just one test is the absolute answer, but really is a composite, like a scorecard of not that one test is the absolute answer, but does your story suggest there could be small fiber neuropathy by burning, tingling, autonomic symptoms of orthostatic and gut motility and dryness? Do you have low blood pressure? Do you have skin color changes? Do you have neurologic exam findings that we would say that are suggestive? And do the QSAR and skin biopsy, if you had them done, are suggestive? So it's not that one thing is the absolute answer, but it's a composite that makes up a scorecard to say this could be small fiber neuropathy. And so there's been a big discussion this year with patient visits and patients coming to us, especially with COVID and long COVID and many of the autoimmune and airless, downless patients when we look at these patients. So it's important to figure this out for patients because about 1 out of 4 or 1 out of 3 people who come to the POTS may have something in that realm, and the testing can be normal. And we know we need research to find better ways to test people. And the testing for answers can mean meaningful treatments for answers to improve people's lives. So that's why this video exists, to at least give a little more explanation for some of the trappings of the testing, the confusion, and the relevance. Very complicated, and I recommend listening to this video again. There's a video called Tingling Legs to listen to. I also recommend to subscribe to the YouTube channel, Wilson Orthostatic Exercise. We're always updating more videos so you can be informed. We appreciate you listening and being part of us. You matter to us greatly, more than you realize. And bless all of you.